Good afternoon, everyone, and welcome to today's webinar titled Cervical Cancer Screening, a review of the guidelines and an update on populations of patients with HIV. I'm Michelle Edelman, and I am the Clinic Systems Coordinator at the American Indian Cancer Foundation, and I have the pleasure of introducing our speaker today, Dr. Amanda Bruegl. Dr. Bruegl is from the Oneida and Stockbridge-Munsee tribes, and she works as a gynecologic oncologist at the Oregon Health and Science University. Dr. Bruegl specializes in the diagnosis and treatment of gynecologic cancers. She enjoys developing relationships with her patients and their families throughout the course of their cancer treatment and has a research interest in cancer prevention and improving access to treatment in the American Indian and Alaska Native population. In her spare time, Dr. Bruegl also enjoys hiking, camping, reading, and traditional Native American beadwork. This is the second webinar in a three-part series dedicated to women's health-related topics. We've allotted 1 hour for today's webinar, and you'll have several opportunities to ask Dr. Bruegl questions throughout her presentation. If you have a question, please type it in the chat box. Or if you're watching live with us on Facebook, enter your question in the comments section. If we don't get to everyone's question, an email will be sent out with responses from Dr. Bruegl after the webinar today. If you do have questions after the webinar, please send an email to health@aicaf.org, and we will send a follow-up email answering the questions. Also, be on the lookout for a brief survey and an email containing the recording of today's presentation. I'll now let our speaker, Dr. Bruegl, take over so she can present you with new information or give you a great refresher.
Okay, hello everyone and welcome. I'm really excited to give you some updates on cervical cancer screening. It's a difficult topic to make interesting, so I'll try to keep it robust and fresh for you all. Okay, next slide. Some of today's goals, next. First, let's just talk about the scope of the problem. What are the trends in cervical cancer and cervical dysplasia in Indian country? Next. Then we'll move into the cervical cancer screening guidelines. And then last, we'll discuss cervical cancer screening in special populations, patients with HIV, and I also extrapolate some of these guidelines to my immunosuppressed patients. If time allows, I have a few slides talking about HIV-positive women and gynecologic care in general. So first, cervical cancer incidence among Indigenous women. As you can see on this graph, the yellow is the Native population and turquoise is non-Hispanic white. Cervical cancer among all ages is something that increases as you get older. Very, very rare in women who are 21 and younger, which is why the guidelines don't recommend screening before the age of 21. And you can see that at middle age is when it starts to peak. For Native women, there's about 1.5 times the rate of cervical cancer incidence as compared to the non-Hispanic white population. Next. In terms of mortality, you see more of a difference between the two populations. Again, the yellow designates the American Indian Alaska Native women, and the turquoise is non-Hispanic white. You can see that for each age group, Native women are more likely to die of cervical cancer than the non-Hispanic counterparts. This discrepancy is largest at the age greater than 85 years. I think there's multiple things that can contribute to this. One is numbers are fairly small in this population, so small changes can lead to big statistical impact. In general, the mortality rate for all regions of the US is about 2 times for Native women compared to non-Hispanic white. Things that contribute to this are decreased access to care for screening and prevention, as well as a later stage at diagnosis. Next. So before we get into screening, I just want to make a little plug for prevention strategies with cervical cancer. It is preventable. Next slide. So we have 2 prevention tools in our toolbox. Next. There's HPV vaccination as well as the pap smear. Next. HPV vaccination is a form of primary prevention. This means that we can prevent the disease, cervical precancer or cervical cancer, with the use of HPV vaccination. Next. The pap smear is a form of secondary prevention. Secondary prevention is where you may not prevent the disease, but you can detect it early as opposed to late stage. Next. The pap smear is important because it can help with this detection of pre-invasive disease so you can treat before a cancer develops. If there is a cancer detected, women who are getting regular pap smears are more likely to have detection of early stage disease, which has a better prognosis and is more curable than late stage. And many women who are diagnosed with cervical cancer are young, in their 20s and 30s, and have not completed childbearing. So for women with early detected cervical cancers, there are some fertility-sparing options if it is detected early enough. Next slide. So primary prevention is the key, and I'm going to spend a few seconds on the vaccination. Next. Next. So over 100 types of HPV exist. Next slide. 14 to 17 of these have been associated with cervical cancer worldwide. Also impact with anal cancer, penile cancer, oropharyngeal cancer. The numbers listed below show you the types that have been associated worldwide. 16 and 18 account for about 70% of all newly diagnosed cervical cancers in the United States. Next. Okay. So in terms of HPV, as I said, there are 100 types. So there are oncogenic or cancer-causing, and depending on which literature you look at, it can be between 13 and 17 different types. And then there's non-oncogenic. So there are types that cause different issues within the body, often genital warts or warts on the foot or hand, things that are not associated with cancer. Next. You can further subdivide the cancer-causing types into two sort of populations. There's the transient infection. This is a virus, and our immune systems usually can be poised to treat this infection and clear it. The majority of women who are exposed to HPV at some point in their lifetime will clear it within 2 years. Individuals with persistent infection, where for whatever reason the immune system is not able to detect and clear the virus, are the ones that are most concerning for the development of precancer and cancer. Next. So numbers 1 and 2 are the two most common contributors to persistent infection. So again, HPV 16 and 18, most common in the United States, most commonly associated with cervical cancers here. Additional factors that can contribute to persistent infection are smoking. Smoking can be immunosuppressive, and it can prevent your body from clearing the virus. The next one is any form of immune compromise. Patients who have a history of a transplant, rheumatologic disorders or lupus where you're on immunosuppressive medications, Crohn's disease, these individuals have a less robust immune system and would be potentially less likely to cure the virus than someone who's not on these medicines. Additionally, HIV or AIDS also compromises the immune system and decreases the ability to clear it. And then increasing age. As we get older, our immune systems are less robust as they were when we are in our teens or early 20s, and this can be associated with decreased ability to clear the virus. Okay, next. Here are the vaccines that are currently FDA approved in the United States. On the far right is the one that I highly recommend for all patients as able. So this is a vaccine that covers 9 different types of HPV. 7 of them are high-risk HPV associated with cancer. HPV subtypes 6 and 11 are associated with genital warts. As you can see, there are contraindications or if patients have allergies that are listed below. But the best coverage comes from the 9-valent. However, administration of this vaccine of any variety will be of benefit to patients. Next. Here is just a brief summary of the vaccination schedule. In terms of how many vaccines you need, new guidelines have been published in the past year. For individuals who are healthy with intact immune systems between the ages of 9 and 14, they will only need 2 doses to have full effect from the vaccine. Typically, you will do this 0 and 6 months apart, or if the patient is unable to follow up in 6 months, you can repeat it in a year. You do not have to repeat the series. If a patient is immune compromised in the younger age group, or if they are 15 to 26, then they still need the full vaccine series. So 0, 1, and 6 months, or 0, 2, and 6 months. These schedules are pretty hard for busy school children, and so if they are longer in between intervals, you do not need to restart the series, just continue where you left off. Okay, next. Okay, so that was our brief rapid review of HPV vaccination. Here is our first poll question. Do you currently offer the HPV vaccine to your patients? And are we able to see the results, ACAF crew? There we go. The 5 of you that voted all 100% do. Excellent. We're going to move on to the next slide. Are there any questions about HPV vaccination? You can either type in using the chat or the Facebook link. All right, it sounds like we have a lot of professionals in here who are very comfortable with this. Good for you. We'll move on to the next part. So let's talk about cervical cancer screening guidelines in the general population. Next. So first I want to point your attention to an app that I use exclusively in clinic. It's the ASCCP mobile app. It costs about $10. The app updates as guidelines are updated, which is really nice as these continue to change, I feel like, regularly. You can put in both the screening guidelines and the management guidelines. So you can just plug in your patient's information and follow on this app. Okay, next. So here are the basic nutshell guidelines. If a patient is less than age 21, there is no screening that is recommended for them. Individuals may be, if a patient is often exposed to HPV if they are sexually active. However, this age group is immensely good at clearing the virus on their own, and cervical cancer is so rare that we don't proceed with putting young women through the trauma of a pelvic exam at this point. Starting at age 21 up until age 29, the recommendations for cytology only and every 3 years. So just a pap smear. HPV co-testing is not likely to be of great benefit. Many people in this age group will be in that part of their lives where they are exposed but will clear it. And cytology has been shown to be sufficient for monitoring for more concerning lesions. Starting at age 30, there are 3 options. So the recommended option at this current time, but maybe changing shortly, is HPV and cytology co-testing. This can happen every 5 years if they are both negative. Additional options, if HPV testing is not available in your clinic or your site, you can continue with the cytology every 3 years. Something that's now making some press and that is newer is HPV testing only. And this can be done every 3 years. We'll spend some time talking about the HPV algorithm because my anticipation is that over the next 3 to 5 years, the US may proceed with HPV testing as the preferred method. After age 65, women no longer need to be screened, but there are some caveats. So unless a woman has a history of moderate to severe cervical dysplasia or adenocarcinoma in situ, you would continue screening for 20 years following that diagnosis. So for example, if a woman is age 55 and she has an abnormal pap smear and a biopsy that shows CIN2, and she's treated with either a cone or a leap in the office, you would continue screening her for an additional 20 years past the age of 65. Okay, next slide. All right, so let's talk about the primary HPV screening. This is going to have, I think, a lot of evolution over the next period of time as more and more research studies are published on this. So first, you can start with a primary high-risk HPV screening. At this point, most commercial availability is a swab that either goes in the vagina or in the cervical canal. Next. So once you do this test, you either get a negative or a positive result. Next. If it is negative, then you can proceed with routine screening. So I put a star here because routine screening is still evolving, but at this point, most of us are repeating high-risk HPV screening again in 3 years. Next. If the HPV screening is positive and your lab is able to, you triage to is it HPV 16 or 18 or one of the other high-risk HPV subtypes. Next. If it is HPV 16 or 18, you can proceed directly to colposcopy to look for visible lesions and the need to biopsy. Next. If it is one of the other high-risk HPV subtypes, then you can proceed with doing a pap smear. Next. If it's a normal pap smear with a high-risk HPV, you can follow up again in 12 months. Follow-up can be either co-testing or repeat HPV screening. If the cytology is atypical squamous cells of unknown significance or worse, next, you will proceed with colposcopy. Okay, next. Okay, so there are some additional caveats and questions that many people have. So next. What if the patient's had a hysterectomy? Next. So if the patient has no history of moderate or severe dysplasia, no further screening is needed. So she had never had an abnormal pap. She has a hysterectomy at age 35 for uterine fibroids or heavy periods. She doesn't need screening of the top of the vagina or the vaginal cuff. I still recommend a pelvic exam for women who still have their ovaries, but the pap smear itself isn't necessary. Many times patients don't know their pap smear in as full detail as we would maybe like. So typically I'll ask questions of, have you ever had an abnormal pap smear? Have you ever had a procedure on your cervix where they've needed to take a small biopsy? Have you ever had surgery on your cervix? Sometimes these things can help you sort of triage history when all the details aren't there. Okay, next. If the patient had a history of moderate or severe dysplasia, you would continue with age-appropriate screening for 20 years. So you would just do a pap smear of the vaginal cuff, and you would follow the guidelines for colposcopy or biopsy based on that pap of the vaginal cuff. Okay, next. What if the patient's been vaccinated? Does she still need screening? Next, and the answer is yes. As you could tell by the vaccines that we talked about earlier, some of the vaccines cover more or less, but none of the vaccines cover all of the high-risk HPV subtypes. So at this time, it's still very important that they continue with routine screening. Okay, next. Okay, poll question number 2. Prior to today's talk, has everyone heard of the ASCCP app? Okay, so it sounds like some new information has been provided in this section. The $10 sometimes is a little bit of a barrier, but I do find it really, really helpful. And anytime one of my consultants call or ask me a question, I go to that first, and then if in the rare cases where the app can't actually answer my questions, then I'll dig out those publications and go through the fine print. I get no money for saying that. I just really think it's a good tool. Okay, next slide. Okay, any questions about cervical cancer screening in the general population before we move on to special populations?
Hi, Dr. Bruegl. We have a question.
Okay.
For screening in 65 plus category, if they've had a abnormal PAP and you're suggesting continuing screening for 20 years, is that continuing on the every 3 years or yearly?
It would depend. That's a great question. So it would depend on what their abnormal was. So let's say that they had CIN2, so moderate dysplasia that was treated at the age of 58. You would do the screening through kind of standard guidelines. So let's say they had CIN2 and they had a LEAP with negative margins. You would typically do something like co-testing for the next 2 years, and then you would continue with the every 3 to 5 year screening from the time of the LEAP. So if the LEAP's at 58 and you did those 2 years of enhanced screening, you would do routine screening until 78 years of age.
Thank you. Yeah, and we have one more question.
Okay.
So we understand why we don't need to test for HPV in the 21 to 29-year-old range. But what is the benefit of testing once people turn 30 if they're also getting the PAP every 3 years?
So the benefit at 30 is that HPV is So many layers to this question. So starting at age 30, this is when our immunity as adults starts to become a little bit less robust than it was when we were younger. So people who have HPV at older ages are just at a little bit higher risk of having persistent disease. So this adds an additional element for us to screen and surveil for the development of precancer or cancer. One additional benefit, I think, is that for many women, the HPV will be negative and their Pap will be normal. And so then you have 5 years of time before you need to have your next Pap smear. And most women are pretty excited about that. And so that does provide a little bit of increased time in between visits. Did that answer your question?
Yes, thank you.
Okay. All right, let's move on to the cervical cancer screening and the special populations. These will be focused primarily on women who are HIV positive, but in my practice, I also include this for women who are immunosuppressed for other reasons. So Crohn's disease, who are on things like Remicade or rheumatoid arthritis, because I tend to see a higher number of these patients in my patient or my clinic panel. Okay, so next. Okay, so some facts about HIV, just to start us off. So about 24% of HIV positive individuals in the United States currently are women. Next. In the United States, heterosexual contact is responsible for about 74% of HIV transmission. IV drug use accounts for 23% of the new HIV cases per year. And in terms of women's health and obstetrical health, about 2% of new HIV cases are due to perinatal transmission. For women who are pregnant or thinking of becoming pregnant, there are really good medications and practices that can be done to help reduce the transmission risk to the baby. Okay. This next slide is pretty wordy. I'll let you take a look at that on your own. But when do you screen women for HIV? And this has evolved over time, but according to the CDC and then ACOG, or the American College of OBGYNs, all females between 13 and 64 should be tested at least once in their lifetime. And then annually based on risk factors. As you can see, there are a number of well-known risk factors listed here. But IV drug use, enhanced sexual risk behavior, women with bisexual partners or have had sex with men who have had sex with men since their most recent testing are all individuals who may benefit from a yearly testing of this disease. Additionally, anyone who's in the healthcare field or a surgical field, I will often recommend yearly testing, as there's an increased risk of contact through kind of daily work life. Next. All right. So when to start and stop screening in an HIV positive patient. Okay, next. So this is a unique population where you actually will start screening women before they are 21 years of age. So for young women, you should begin screening within 1 year of diagnosis. So for example, if a woman is tested for HIV at the age of 17 and tests positive, you want her first Pap smear to be within that first year of diagnosis. These women are going to be less likely to clear the virus and more likely to proceed to cervical dysplasia or cancer than their other non-immune compromised counterparts. Next. Additionally, if a woman was born with HIV or contracted for some reason in childhood, well before sexual activity might have started, you want to start screening within 1 year of sexual activity. So if a child was born with HIV and becomes sexually active at the age of 14, you want to start Pap smears within that first year. Next. And unlike the general population, you never stop doing Pap smears. You want to do this for the duration of a woman's lifetime. She will be immunocompromised through her medical condition, even if it's optimized, throughout her lifetime, and therefore you will not stop screening at any point, unless she says, I would not act on this, I would not treat this if something were to develop. But that would be a rare situation, I think. Okay, next. In terms of sort of how often, this is also different. So for a young woman who is less than the age of 30, if your cytology result is normal, You repeat it again in a year. If you have 3 years that are all normal, you can proceed with then every 3-year cytology. But you really want to get a good pattern of normal and close surveillance before you start spacing things out in this at-risk population. Next. HPV co-testing is still not recommended for young women with HIV who are less than 30 years old. Next. For women who are age 30 and older, the screening options are a little bit different. So you can proceed with the cytology alone, just like the women less than 30 group. You still want to repeat it every 12 months for 3 years. And if all are negative, you can then move on to every 3-year cytology. My preferred option for the 30 and older crowd would be to proceed with co-testing. If the pap smear is normal and the HPV is negative, you can repeat co-testing in 3 years. Unlike the screening population of non-immune compromised individuals, where you can go 5 years, we are making this a shorter interval, so every 3 years co-testing. If the woman has a normal pap smear but she's HPV positive, you're going to triage her to routine ASCCP guidelines and follow up. Okay, next. We're going to move on a little bit to unique women's healthcare issues in HIV positive women. So bacterial vaginosis. There does appear to be an increase in the frequency of BV in HIV positive women compared to women without HIV. The exact pathway for this is not entirely known. Okay, next. The treatment management, fortunately, is the same. Here are 2 management strategies. There's clindamycin and then there's metronidazole. Any one of these regimens is fine. Whatever you think that your patient will take and use is the best one to use. Some women prefer pills, someone prefer the vaginal route. Either is fine. Okay. Next. In terms of yeast infections, next. It's diagnosed and treated the same as HIV negative women. Next. However, it's important to do a vaginal culture to confirm Candida albicans. Women with HIV are more likely to have severe or recurrent infections, so they should be treated with oral fluconazole or topical antifungals for 7 days. For women who have repeated yeast infections, you can consider doing a 7-day treatment with topicals, or you can do 2 diflucan or fluconazole treatments, so day 1 and day 3. And once that infection is cleared, you can consider doing fluconazole weekly for 6 months. Because these women are more likely to have these repeated infections, it can be much harder to treat. If you are doing a prolonged fluconazole regimen for these women, this medication is metabolized through the liver, so it's important to get LFTs once a month to monitor liver function, especially since some of the HIV medications can also impact the liver. So I would work closely with their infectious disease provider or the primary person managing their HIV if you're going to consider pursuing this route. Next. Okay, general STI screening recommendations for HIV positive women. So at the entry to care, it's highly recommended to do a PCR-based gonorrhea and chlamydia test, syphilis testing, trichomonas testing, as well as hepatitis B and C. Next. Annually, it is recommended that you continue with PCR-based gonorrhea and chlamydia testing, syphilis, and trichomonas. Next. The good news about HIV positive patients in STI treatment is that much of it is the same as the regular patient population. For this information, I go to the CDC website or I use the CDC app for treatment of sexually transmitted infections. The only one in this list that is unique and slightly different is the treatment of trichomonas. So rather than doing a 1-day single dose scheduled treatment, the CDC recommendations are for metronidazole 500 milligrams daily for a total of 7 days. And with all of these infections, it's important to test for reinfection. Most guidelines will say retest in 3 months. Again, depending on your patient population and the unique patient characteristics, you can do that sooner or later based on your clinical judgment. Next. Okay, our final poll question today. prior to us talking, did you know that there were different cervical cancer screening guidelines for HIV positive women? About 50-50. These guidelines came out maybe within the past year, and it's still really making its way into clinical practice. So I'm glad that I was able to provide a little bit of information to half of you. Okay, next. Are there questions about cervical cancer screening in HIV positive women or any of the basic GYN care?
Hello, this is Amber at the American Indian Cancer Foundation. And I just want to remind all the participants, or let you guys know in case you're not aware, that there's a chat function. It looks like a little bubble with 3 dots in it where you can type questions if you have them. And we do have a couple from Facebook, so I'll start going over those, Dr. Bruegl.
Okay.
One says, I know you already covered getting tested after hysterectomy, but does that also apply for individuals who are immunosuppressed?
As of right now, yes, those guidelines would be the same for the immunosuppressed patient. If a patient had a history of high-risk HPV and they had a hysterectomy for other reasons, I would probably talk to them on a one-on-one basis to talk about whether or not we would continue screening for vaginal dysplasia. But that would be very much a one-on-one discussion with that patient. That's a really good question.
Thank you. Another one we have is, what if a woman has a normal Pap but a positive HPV test?
So that it depends on the age, but often in the 30 and older crowd, you'll do colposcopy to look at the cervix to see if there's any abnormal lesions or changes that are concerning. If it's her first one, and she's had routine testing, I think this is where I'd actually put it in the app, I hate to say, but I think if they're 30 or younger, you can repeat testing in a year.
Okay. Thank you. We have another one that says, as a family member, what can I do to support someone that has an abnormal Pap smear?
Mm-hmm. That's a really, really good question as well. I think as we are learning more and more about HPV and that it's a virus that is transmitted sexually, there can be stigma associated with having a Pap smear that shows this. Many women feel ashamed and that they've done something wrong. And I think as providers, we need to educate our patients and let them know that this is an incredibly common thing, and most human beings on the earth will be exposed to this at some point in their life. And so as a family member, I think, if there's a family member who has a similar personal story, sometimes sharing that can be helpful. But I think really sort of normalizing, but sort of helping people understand that this is common. It's kind of like the common cold of the cervix, and that it's not a marker of being unclean or unsafe, but that it is just something that is. And you know your family member best, but I think just trying to be as laissez-faire about it as you can, I think, can be really helpful with decreasing stigma and keeping communication channels open in the future.
Thank you. We have another one that just came in. How does screening work if a woman has an immunosuppressant disease like lupus?
So technically, according to national guidelines, you wouldn't necessarily change your management. You would treat them like a normal screening population, a general population. For me, when I see patients in my practice, I will look at the medications they're on and look at their cervical Pap smear and HPV testing history and make a determination of whether I want to triage them into the more high-risk category, like the HIV positive category, versus keep them in the general population. If someone is on strong immunosuppressive medications like the biologics like Remicade and things like that, and they've had sort of persistent low-grade cervical dysplasia, I will talk to them about being more conservative and doing testing a little bit more frequently. But that's very much a case-by-case basis. But I think the most important thing for the immunosuppressed patients is that they understand that they are at higher risk and that it is very, very important to stay up to date with their provider and make sure their provider knows kind of everything that's going on from a medication standpoint. Looks like there was a great comment here from Holly Lawson from Survivor. Correct me if I'm wrong, Holly, but it's a great organization meant to help support women with diagnosis of cervical cancer and HPV, and I think there's also support for men who have HPV-related diseases. And she's put in the link on the chat for Survivor, CERVIVOR.org, that provide stories and support for women. Thank you for sharing that, Holly.
Yeah, thank you, Holly, and I'll be sure to post that too in the Facebook comments so everybody has a chance to see that.
Okay, next slide. Thank you so much for your attention and your questions, everyone. Join us on July 25th. We'll talk about the management of abnormal pap smears. And to make the discussion just a little bit more interesting than me reading guidelines, please submit cases, things that you've encountered in your clinics or your practice, and we can talk about the guidelines through your personal, or not personal, but your clinical cases. So send them to us by Friday, July 13th. We'll get an email to you. There you go, health@acaf.org. And we will get you, we'll try to get your case incorporated into our discussion.
Alrighty, thank you so much, Dr. Bruegl, for sharing this information. And I want to take a time to thank all of you for attending today's webinar in partnership with the American Indian Cancer Foundation and Dr. Amanda Bruegl. And just as Dr. Bruegl said, please join us on Wednesday, July 25th from 1 till 2 p.m. Central Standard Time for our third webinar, again, about the management of abnormal cervical cancer screening tests. And if you do have that abnormal or unique case or a question, please send the information to health@acaf.org, again, by this Friday, July 13th. We will be sending out an email shortly with the recording of today's webinar, as well as the information about the case studies and registration information for that webinar. In addition, an email from Robert Spencer has or will be sent out shortly that includes a brief survey about today's webinar, and we'd really appreciate it if you could fill that out and give us feedback so we can continue to improve and build upon our webinars. And thank you all for joining today, and have a great rest of your day.